right, so we're good. All right, so I want to thank everyone for coming out here. We're about to do some neuro. We're going to wait for this to connect, which it should, because I just plugged it in. Cool, all right, so let's get started. So first off, a little note about orientation. I know it was the first lecture, the first slide, the first page in the essentials. Don't forget that weird thing that happens at the midbrain when we do that flexure, where dorsal and ventral kind of switch and anterior, posterior. So I just want to bring that up. Look at that page again. You will get they can bring up something that has to do with that. Let's keep it nice and vague. Okay, so let's talk about embryo real quick. So we know that we have kind of 5 divisions embryologically. We have our telencephalon, di, mes, met, and mi. What this can allow me to do is not only obviously the embryo of it, but I can understand things like vasculature. I can make a lot of different connections about cranial nerves and of course my ventricular system. So one thing I want to bring up is please remember this. We want to know that our telencephalon, which is associated with our cerebral hemispheres, is associated with our lateral ventricles, which are located in our cerebral hemispheres, and cranial nerve 1, which means if I have a development problem in telencephalon, I will have a lot of problems, but cranial nerve-wise, I'll have olfactory problems. Of course, because it's the cerebral hemispheres, you'll see a lot more kind of problems there. This comes kind of bigger when you actually hit the brainstem, but we know diencephalon now is associated with my thalamus, hypothalamus, all that good stuff. Cranial nerve 2, important, and my third ventricle, so not as high yield. But now let's go into the mesencephalon. So mesencephalon has my cerebral aqueduct in my ventricular system. This is important. We're going to talk about ventricular system, but this is important because it's the easiest place I could get impinged to have obstructive hydrocephalus, so that's a key word right there. Cranial nerves 3 and 4 are They come from the mesencephalon, and if we know from anatomy and things like that, we know that my SCA and my PCA are my blood supply to cranial nerves 3 and 4, which means now I can kind of extrapolate that and know that SCA and PCA give blood to my midbrain, because that's my mesencephalon structure. Does that make sense? You can make those ties. Things I can say for cranial nerves located in certain parts of the brainstem, if I pull back and I look at the embryo of it, I can assume the vasculature is the same. You can make those assumptions here. So that's kind of what I wanted to say about that. Please don't forget that the cerebellum is part of the metencephalon. Lots of people want to say mi. That's all I'll say about that. Don't get tripped up if they use weird words, like the correct answer would be something like, where does the cerebellum come from? And all you can see is rhombencephalon. Well, that's a right answer, because rhombencephalon contains my metencephalon and my diencephalon. So some keywords there. I like this picture in Essential, so I just kind of included it there. Myelin is the spinal cord, if you haven't seen that word before. Lamina terminalis, really kind of obscure thing, but I was going to ask, like, what is it? But it's the closure of the rostral neurocore. So we know that we have rostral and caudal, and if we don't close our caudal neurocore, we have spina bifida, right? If we don't close our rostral neurocore, we have yes, exactly, anencephaly. But what you should know about lamina terminalis is that it's located in the third ventricle, which means it's kind of associated with my diencephalon, right? Because I can say third ventricle is by my thalami and things like that, and I can say that that is part of my diencephalon. Okay. Oh, please know this. Okay, so you know how you have that lecture of, like, you have your granular cells, your Purkinje cells, like all those weird, like, molecular layer, like in every layer of the brainstem, or in the cerebrum and things like that. We know that sensory comes in through layer 4, and motor leaves out through layer 5. What does that mean? If you just need to straight up memorize it, that's cool, but let's take it another step. Let's say, okay, how are they going to ask this in a question? Well, we could talk about my motor cortex, right? So this is going to be my precentral gyrus, right? So we could say, what layer is going to be, you can say, like, enlarged in that area? Well, it's going to be 5, right? That's my major motor area, so that means that my layer 5 is going to be huge, because it's going to be, in charge of that. Well, in my postcentral gyrus, layer 4 is going to be very important. In my occipital lobe, layer 4 is going to be very important. So keep that in mind. Sensory in through 4, and motor out through 5.
The mnemonic that someone showed me is like, when you're when you go inside like a office building, you go in through the lowest level, but then all the higher ups are higher above you, so motor comes out through 5, sensory comes in through 4. I don't know. They just told me.
Cool. So, okay, this like really obscure thing. Who knows what Redlich, Orbert, Steiner, Orville, Redenbacher, or whatever this guy's name is? What is this? It's my junction, exactly, between my CNS and my PNS, and it's also very good popcorn. So, honestly, that's how I remembered it, because this looks like Orville Redenbacher to me, and I don't know how I integrated CNS and PNS there, but don't forget this. It's a very random word, but hopefully now that I said it and brought it to your attention, you're gonna kind of just like remember this moment and, think of me. Okay, so let's talk about the note of Rambier. You guys have note of Rambier. I'm sure you've heard of it a ton of times. Don't forget, this is like those little jumps between our myelin that allow saltatory conduction. Okay, so you guys learned about like all the different lobes and stuff like that. They can be very nice to you and say, what is occipital lobe in charge of? And you can say vision. It can be that straightforward. Don't forget, limbic lobe is kind of that awkward one. You haven't really learned too much yet, but we know that our hippocampus and amygdala are a part of it. So let's talk about those for a second. I know that you guys possibly have had a question that kind of showed this picture once before, because I know that we had it in Sakai, and they basically pointed out this little structure, and they said, what's going to happen if you lesion this? And the answer would be memory problems, right? You don't need to know the exact issues yet because you haven't had the lectures, but we know that if we damage our hippocampus here, we're going to have memory issues, and if we damage our amygdala, we're going to have problems with emotion, strong, intense emotion like fear. Okay, but these two look really similar, so how am I going to remember this? Well, here I can see my pons, right? I see my beautiful brainstem sitting there. Personally, like the way I remember it is my hippocampus has a little hippo sitting underneath, right? This like large structure sitting down there. When here, my amygdala is more anterior, let's start with an A, and we know that cut is not going to include any brainstem, because I could point right here, and this is my amygdala right here, my left-sided amygdala, which is basically in the same position as my left-sided hippocampus. Hippocampus just being a bit more posterior, right? So keep in mind those little connections and how they can make some tough questions, but if you read it again, it wouldn't be so tough. Another thing I kind of want to say is a test-taking tip. If you are not able to deduce the right answer within a few seconds or know what the question is asking, please read the question again or move on, because the neuro department doesn't ask that difficult of questions. The problem most of the time is knowing what they're asking. So if you don't know what they're asking, move on and come back to it, because they could literally just be saying, what does the hippocampus do, but you're looking so far into it, you kind of pass over that. Okay, keep on moving. So the fornix, essentially you just have to know if you lesion this, what's going to happen. So I need to know that my fornix is associated, and if these, okay, let me kind of prequel this. If these pictures and things like that are like, where did you get all this information? This is from the essentials. If you have not yet read all of the essentials, that is okay. Try to read them before this exam. I know they didn't provide them to you, but every objective is testable and every objective is answered in the essentials. And basically what I'm trying to say is whether they give them to you or not, you're expected to know them. Sorry.
Also, just a disclaimer, your exam will not resemble the questions you've been asked in Clicker.
Oh yeah,
not
exam is way easier.
Listen,
yeah.
You are gonna walk out of that exam and you're gonna be angry because you're gonna be like, is this a joke? Did they torture us on purpose? Like, I swear to God, it is not going to be like the Clicker session.
Yes. Oh, you guys are good. Don't worry about that. Like, we're kind of bringing the fear right now, but we want you to study hard so that you guys rock it. Yes, question?
Just a question. So, on our Clickers, they usually give us like 8 from J.
No.
No?
They will not give you 8 answer choices, not even on our exam.
Yeah, they did. Yeah, they did. Yes, they did. I'm going to move on, and yeah, they did. They did. So the question was, how many answer choices for my people listening in? How many answer choices do they give on the exam? And yeah, there are a ton. And if there aren't, well, that's great, but study like there are. Okay, so fornix, essentially it connects the mammillary bodies with the hippocampus, and this little squiggly line here kind of demonstrates that, because we know our mammillary bodies are situated anteriorly to my midbrain, and then my hippocampus is kind of sitting lateral, right? So they do this kind of like weird C-shaped thing sitting laterally. Long story short, what you need to know is that it's going to affect memory, right? Anything that touches the hippocampus is going to affect memory. And we're associated with our amygdala, so we may have some emotional problems there. But just be aware of this, and the fornix is a bundle of axons, meaning that it's white matter. So let's continue. Okay, so then you guys have like, the thalamus has like a ton of different like associations like within it, different nuclei. Nuclei we use kind of loosely. Do you guys need to know this yet? Maybe. So what I want to say, so these are all kind of part of the thalamus. So you have your lateral geniculate body. All you need to know, lateral light. I'm talking about vision. Medial, I'm talking about music, hearing. So that's kind of what you need to associate with that. Then we have my VPL and my VPM. And this you probably learned about in sensory. And my VPL is going to have all my sensory for my body, whether it be pain, whether it be touch, vibration, proprioception, temperature, all of it is going to my VPL. While my VPM is going to do face. And as far as I know, you guys have not done face yet, which is awesome, so you probably don't need to know that much yet. Okay, let's talk about white matter. So there's 3 types of white matter, right? Association, commissural, and projection. So I personally like to learn things through like a scenario, which means like how they can ask a question, right? So I'm gonna grab my phone, and let's just say my eyes were closed and someone put this in my hand and I didn't know what it was. So I'm putting my phone in my left hand. I don't know what it is. So what's gonna happen is the sensory is gonna travel, right, up my left side. It's going to travel on the left side, it's going to go up my spinal cord, right, it goes through, we'll do a little bit more with that in sensory, and it's going to cross over, right, in my medulla, right, and then ascend to my right cortex. And what I can say is that I used projection there, right, because I went from subcortical to cortex, right, so that's projection matter, and how I like to remember that is P has a nice long stem, right, so I think P is going from subcortical to cortex. So after that, I need to know, okay, what is this? So my sensory went to my right cortex. Now I need to know, okay, what is this thing? And I know that my comprehension system is Wernicke's, right? My Wernicke's area, which is only located on the left side of my brain. So I need to cross from the right side of my cerebral cortex to the left side of my cerebral cortex. And what kind of white matter am I going to use there? Commissural, right? My commissural fibers, which is my corpus callosum, is the biggest example of that crossover from right side to left side. So I just remember that with my C's, right? Crossing, commissural, corpus callosum. So then my last fibers will be association. So now I have to move from Wernicke's to a different area. Let's say I want to say what this is a phone. Well, now I need to move to Broca's area. So it's both on the same side of the cortex. They're both localized to the left side, which means that, okay, now I'm using association, moving from this side to this side. And why I use that kind of extended example is because that's how it could be asking questions. They're not going to say, what is the corpus callosum? They're going to give you a situation where it was used and then say what kind of white fibers were used there. And I kind of tried to write out the example that I was going to use there. And some definitions. Major example of the projection fibers is going to be your internal capsule, so just remember that. An internal capsule is also very special because it's one of the areas where I can lesion both motor and sensory, and I know you guys haven't done motor yet too much, but that is something you should know by now, just generally, is if I lesion my right internal capsule, I'm losing left-sided sensory and motor. Okay, so moving on, homunculus. Rumor has it, no one really went over this with you guys. So we got this in like our first lecture, and it's really important. So I just want to put this picture here just to emphasize how important it is. Obviously, I can't teach this because it's just kind of a thing that happens. But we know medially we have foot and knee and stuff like that, and then more laterally it's going to be things like my face. Know this picture, it's really important, it's good. And just like in context, this is located in my precentral gyrus as well as my postcentral gyrus, right? Because it's the same kind of pattern that follows motor and sensory, right? So it'll look like this, there's a cut like this, and then a cut like that just behind it, one controlling motor, one controlling sensory. I hope that kind of made sense. Okay, this is something that tripped up a lot of people. Because let's just say they ask a question like, okay, someone loses sensory in their leg. And the options are going to have either side. So let's just say right leg lost sensory. So they'll say left lateral postcentral gyrus. Well, a lot of people are inclined to choose that because it says postcentral gyrus, but we know in my homunculus here that leg is located medially, so I need to choose a better answer than that. So a better answer than postcentral gyrus is actually my posterior paracentral gyrus. And I know that maybe this doesn't sound too familiar, but essentially it's just a cut on the, this mid-sagittal cut in the brain, and this is my central sulcus. So laterally, we would call this my postcentral gyrus, but right here, I'm gonna call it my posterior paracentral gyrus. So these are images that are in the neuroanatomy book, so it's fair game. They brought it up in lab. You guys have to go over this plate in lab, which means they can ask questions like this. So I just kind of want to point that out, that you have an anterior paracentral and a posterior paracentral, and those are going to be in charge of lower limb, right? Cool. So this is basically just saying, like, they can give you like a pattern of like, oh, tell me the pathway of sensory. Well, when they say something, straightforward as that, make sure you're starting in the periphery, because sensory starts out here, and I know this sounds straightforward, but they'll have the same answer choices, just like an inverted, number of order that they go through. And motor is gonna start in the cortex. So just keep that in mind. Of course, I answered my own questions here. So
just to piggyback off of what she said, so if they ask you where are the cell bodies for motor neurons located, where are they? In the cortex. That might resemble maybe something that they might ask you. Maybe.
Cool. So then they could kind of describe a transient, okay, so like moving, I know we're like just flying through concepts here, but I just want to make sure I hit everything. We have things called like a transient ischemic attack versus a reversible ischemic neurological defect. And because it says reversible, more people are inclined to choose this and like as like the least mild one, but reversible doesn't exactly mean that full recovery. Transient ischemic attack always has full recovery. Reversible actually lasts longer than 24 hours and could cause damage. Most of the time there is most recovery, but just remember transient ischemic attack is transient. It's only gonna last a few seconds. Keep that in mind, that is much more mild. And it's less than 24 hours. Okay, imaging. And I want to say you guys maybe had this on exam soft question or something like that, just knowing what a DSA versus cerebral angiography looks like. So this right here is an example of a DSA, so digital subtraction angiography. And I know that because I can't see like anything else other than what I'm trying to look at here, which is my carotid artery, my internal carotid. If I were to look at this picture in comparison, I see skull here, right? And so this is going to be cerebral angiography. So the first one was digital subtraction. I subtracted everything in the background so I could focus just on this artery here, and on this one I did not. So more than likely this is the more testable one, right? Because we could actually see a lot of different structures here as opposed to this guy, which is pretty cluttered with bone and things like that. So keep that in mind. This is DSA, this is cerebral angiography. Okay, moving on. Okay, so you guys had that stupid lecture on imaging. I tried to sum it up as simple as possible on everything they could ask you there, because they're not going to ask you about x-ray and things like that, because you know what x-rays do and CTs and MRIs, but these are the three kind of obscure ones. So fMRIs are going to look at oxygen consumption, PET at glucose, and SPECT at perfusion. Just keep that in mind. Brodmann's areas. I'm not going to go through Brodmann's areas because I thought they were going to be much more high yield than they actually were. And when I say that, I mean like they do not show up for us. But that does not mean that they are not important. So if they were to be tested, this is what they would ask. So this is from like the essentials themselves, and this is a compilation from an upper termer of things that have been asked in the past. So take a look, and I included the image there as well.
More likely than not, they will ask you it in a way. Like if they do ask you any Brodmann's area, they're going to give you a specimen, or they're going to give you like an MRI, but they're not just going to straight up ask like, what is this part of the brain?
Yeah, what Ruby said is they're not gonna ask like, what is this part of the brain, but they're gonna give you a specimen to kind of pick out the Brodmann's area. So, keep it in mind, if you got a lot of stuff to study, leave it at the end of the list. Okay, so hemorrhages, imaging, okay, so I'm gonna fly through these because I'm sure you've heard it a ton of times. I wanted you to be able to see what they are because I can promise you're gonna get one of these images. So, of course, we know that in blood, like if I believe my patient is bleeding, I'm ordering a CT. CTs are fast and I can see bleeds there. So this is a CT. I know that because of the bone here, and then I can see kind of the fatty layer on the outside, and I see this football-shaped hemorrhage. And I know that that's going to be an epidural hematoma, right? And that's going to be football-shaped, easy to remember because football players are at risk. I have a lucid interval here, so literally the presentation is football player gets smashed in the head, kid gets up, no problem, 2 hours later, dead. Very sad, very traumatic. Really important here, it does not cross the suture line, right? We can see it's nicely encased here. And it can cause an uncal herniation. Let's talk about that real quick. So an uncal herniation, we know that my brain it sits in the skull, right? And when pressure increases, this hemorrhage here can either push on the skull or push on my brain parenchyma, right? And obviously my brain is much more squishy than the skull. So my brain's gonna sink in. And when it does that, there's only one way to go, and that's down, right? Through my foramen magnum and things like that. So my tonsils, that would happen eventually. But first, my uncus, which are located kind of laterally, are going to, normally, if it's on this side, right, this is a right-sided hemorrhage, so my right uncus is going to push on the right side of my midbrain, affecting my right cranial nerve 3, causing my right eye to be down and out. Does that make sense? Because my right eye is going to show the symptoms because it's my right cranial nerve, but my left side of my body is going to show the symptoms because we know that my right side of my midbrain holds my left-sided sensory and motor tracts, right? And you don't need to like memorize anything, obscure about that, and don't think too hard about it. Just know some rules stay true, and if you could hold on to those rules that my right side of my body is controlled by my left side of my brain and brainstem, and vice versa, you'll get really far with that. So, yeah, continuing.
So what eye did you say?
So it's going to be the ipsilateral eye. So if it's a right-sided hemorrhage, it's the right-sided eye going down and out. And that's because you're literally pressing on that cranial nerve. And we know in anatomy that the lesions are peripheral, right? So when I affect right cranial nerve 3, it's my right eye affected. But the rest of it is going to be kind of contralateral sensory and motor deprivation, right? Weird concept, good question, so. Okay, this guy right here, so I see this little banana-shaped hemorrhage here, which means I know it's gonna be subdural, and I know that my risk factors for a subdural hemorrhage is a little old lady who hit her head a couple weeks ago. And so what happens is, as we get older, our brain shrinks, right? And it kind of pulls a little bit on these veins, which makes really minor injuries, like tripping, kind of allow the veins to be pulled on and create these subdural hemorrhages. They're crescent-shaped, yeah, old lady falls, that's really the key there. It does cross the suture lines, right? It goes all the way around, unlike our epidural hemorrhage. And confusion is a good symptom, right? So it's like, oh, here's my mom. She was like totally normal 2 weeks ago, and then all of a sudden now she doesn't know what's going on. It's a really acute onset, but still, it still took a few weeks. But for a confusion like that, it's pretty interesting. First thing you're gonna do is order CT. So this could slowly progress into a coma. Most of the time, you're not gonna have the stem present them as in a coma. Oh my gosh, I love this one because it looks like a Christmas tree, and you get a thunderclap headache, right? So they're gonna have the worst headache of their life. Doc, I don't know what's going on, I have the worst headache. And this is gonna be my subarachnoid hemorrhage. It looks like branching tree. So this is gonna be an aneurysm, and they could ask something as straightforward as give you symptoms of, an aneurysm in your ACA or something like that, one of the arteries you've been learning, right? And then they just say, what kind of hemorrhage would that be? And they haven't really talked about it because, you're like, okay, yeah, I know that middle meningeal is epidural, but what is my, subarachnoid hemorrhage? Okay, well, it's like all the ones that you learned, so don't overthink it. So ACA, PCA, SCA, PICA, ICA, all that kind of stuff, those would be a little bit more brainstem, so I'd say ACA, PCA, things like that would give you this. So worst headache of my life, yeah. So symptoms are going to depend on location, but eventually the thing is, since it's subarachnoid, the blood just gets everywhere, and that's what gives it this nice Christmas tree look. Again, they will always include the headache in the stem, which will give it away every time.
And also, if you're trying to decide between a neoplasm and a vasculature issue, acute onset is vascular. Neoplasm is slow onset.
Yeah, for sure. And don't be like afraid to choose a neoplasm, because like I know especially with our class when we would have clickers and things like that, you'll have symptoms that like completely match your vasculature, but it was like this really slow chronic onset, and everyone's so inclined, God bless you, to choose vasculature because it's what we've learned, but neoplasm is a totally optional answer. So something else I want to include while we're talking about vasculature are these little guys, which are my lenticulostriae arteries, briefly mentioned, but very high yield and very important when we go into our clinical rotations. Why? Because they are very likely to infarct, especially in people that have hypertension, which we know is a very large population. So these lenticulostriae arteries come off of my MCA, and we know my MCA comes off of my internal carotid, which are sitting right there, right? And it's going to come out and go laterally and do the lateral sides of my brain, right? My temporal lobe, things like that. And while it's on its way over there, these arteries are going to give, my MCA is going to give off lenticulostriate branches, which is going to take care of my internal capsule. And like we said, my internal capsule is my major projection fibers, right, connecting subcortical to cortical. And these are going to contain all of my motor and sensory fibers, right, because they have to all travel in one nice little axon bundle to, you know, their respective areas in the cortex down. So why are these important? Because it's one of the only areas where I can say, okay, I have a right-sided infarct in my lenticulostriae arteries, so I'm going to lose left-sided sensory and motor. So, you know, pretty important, because most things are only sensory and only motor, and here we can have both.
And that's exactly what I was going to say. So if you have both motor and sensory deficits, you're thinking either internal capsule or something that's affecting the entire part of one part of the brainstem. Does that make sense? There are very few things that affect both motor and sensory, so it's like a dead giveaway.
So this picture is pretty blurry. I just kind of included it because it was a nice little picture to show the circle of Willis, but I think it's like in your lectures and in labs and things like that. I also want to say, like, for anatomy, just don't forget like your cranial nerves that are sitting close to your vasculature. I'm not going to spend too much time on that. I'm going to post a picture of like the Christmas tree mnemonic. So I'll do that right after this. I don't have time to go into it right now, but it's just a little way to remember which cranial nerves are associated with which arteries. So moving on, don't forget your middle cerebellar artery does the lateral side of your brain. Do not confuse that. PCA, oh, cerebral, sorry. And your PCA is going to take care of your occipital lobe. And now, so Ruby just pointed out, I of course had a little mishap and said cerebellar. Do not do that. And I know I just made that mistake. But when you are saying these arteries, say them out loud. So I know that like my pica is my posterior inferior cerebellar artery, and they can ask this super complex question. And in essence, it's asking, what is my cerebellum vasculature? What takes care of that? And literally, they just want pica, ICA, or SCA, and they'll only have one of those as answer choices. So say it out loud, because they can, you know, even though they never really talk to you about cerebellum, they would assume that you know that ICA and pica, you know, give blood to that. So keep that in mind. Again, this was a nice little picture. What I wanted to bring up on this, so this is the anterior side of my brainstem. This is going to be the posterior. And we have my basilar artery here, right? And my basilar artery is sitting on my pons. So just to bring up, like, the anterior part of my pons can be called my basilar pons. So just like terms like that, you can make the stretch and you can make those connections. If they're talking about basilar pons, okay, well, my basilar artery sits on the anterior part of my pons, they're talking about anterior pons. So I just wanted to use that to illustrate that concept. This is a nice picture, take a look at it to make those associations. Okay, so ACA, what I wanted to bring up on this, so it does the medial part of my brain, and we just talked about the medial part is going to take care of my legs, right? My legs, my feet, my trunk, things like that. So if I have an ACA infarct on the right side, I'm going to have a ton of problems, but what they'll test you on right now is losing left-sided, probably motor and sensory, of the left leg. Does that make sense? So a right-sided infarct would give me left-sided issues, and because it's localized to the medial part of my brain, it'll be localized to my leg and trunk. Make sense? If I'm going really fast, I am so sorry, but I don't want to keep you guys here all night. And I will stay after to answer any question as long as you guys need, no problem. I love these images. Maybe they are a little bit more information than you need to know, but I just want to point out some things. So I said earlier that we know that cranial nerves 3 and 4 come from my midbrain, right? And I know this is my midbrain because I see my nice little Mickey Mouse ears, my little cerebral aqueduct there. And I know that PCA and SCA are cranial nerves 3 and 4, and I know cranial nerves 3 and 4 are from midbrain, so I can say that PCA and SCA are going to take care of these areas. So just, do you need to know the exact ones right now? Probably not, but just knowing that these two arteries do give vasculature there. So pons, like I said before, my basilar artery sits right on top there, which means basically my basilar artery is in charge of giving blood to my pons. So no problem there. That one's nice and easy to remember. Pica and Ica and ASA are going to take care of my medulla. What you need to know right now is pica, and one thing I want to bring up is there's a syndrome for this, right? We know that pica infarct is also called a lateral medullary infarct, which makes sense here because it's taking care of the lateral sides of my medulla. It's also known as Wallenberg syndrome, right? So I kind of included here the symptoms you would see. It's in the essentials for, I don't know, have you guys talked about this yet?
No.
No? Okay, so I think it might come up in motor, but it did come up. You guys did? Okay, so they talk about this in neuroanatomy. Would they rather test it later? Probably. Does that mean that it's not testable now? No. So essentially all I want to say is this is called the checkerboard syndrome. So you get ipsilateral face problems, contralateral body problems, and if you can't remember anything other than that, I know it sounds a little bit abstract, but you're going to get, so it's going to affect sensory, and it's going to be your ipsilateral face because trigem is going to come in at the pons and then drop down, which you're going to do probably on Tuesday right after your exam, and I don't know why they put your exam literally in the middle of sensory, and then it'll mess up your contralateral sensory for your body. So I'll leave it at that. I don't know why they do this to you people. Okay, so ventricles. Okay, what I want to say about this, so obviously you have to know your ventricular system associated with embryo. What is really important is knowing that in things like obstructive hydrocephalus, so the most common place is going to be the cerebral aqueduct, you should know the structures that are really close to the lateral ventricles because those are going to be the first things that blow up. And yeah, they could be super nice and just be like, what is this? And the answer is obstructive hydrocephalus, or they could ask for something else. Like they give you a patient that has bilateral sensory deficits. And you're like, okay, that's pretty weird, but maybe what's happening is both of my ventricles have enlarged and are pressing on both my thalami, right? And I know that my thalamus is my sensory relay station. So that would be an issue where I would have bilateral sensory problems, which is really interesting because I can't think of anywhere else that would have that issue. So then I have my basal ganglia near there, and you guys haven't really done basal ganglia, but the extent of knowledge, if you guys are given a strange anatomical area, you should be able to describe it in one word, what it does. Basal ganglia, motor. Do you need to know anything else other than that? No. Cerebellum, motor. Hippocampus, memory. Amygdala, fear. So try to do that so that when you get these questions, they can't throw you off. So my basal ganglia is also located there, so maybe, I can impinge on that. So that's probably a bit lower yield than knowing the thalamus is right near there. Keep it in mind. Okay, this picture will haunt me for the rest of my life. Okay, know where the choroid plexus is, and more importantly, know where the choroid plexus is not. Know where the choroid plexus is not. You see it? Right there. I know it's weird because there's a little bit right there, but no, it's not there. So the anterior part of my lateral ventricles does not contain choroid plexus, which means that it does not make CSF. Do not choose this area because there's a lot right there. Choose this area because there's not much right there. That's all I'm going to say about that. Yeah, they asked me that question. I hate that question. Okay, so my inferior horn, also know that it's called my temporal horn. They have it right here. And know that it's called my temporal horn because it sits in my temporal lobe. So yeah, they can be like, hey, where's the inferior horn of the ventricle sit? And you have to know it's temporal lobe. That's as mean as they can get. So the neuro doesn't normally test little details like that. It's more conceptual, but I think it's a little bit important. Okay, so if I were to block my foramen of Magendie and my foramen of Luschka, which I know Magendie is medial and Luschka is lateral, would this be obstructive hydrocephalus or not? So the answer is not, right? So even though like a lot of people think, okay, well, I'm still blowing up all of my ventricles, right? My lateral will be larger, third, fourth, they're all gonna get larger because it's the bottom of my ventricular system, but that's not true, right? My ventricular system goes all the way down my spinal cord. It goes all the way down to encapsulate all of my spinal cord, my body, like all of those things. So if I block those, that is still obstructive. So we're gonna say block these, obstructive, right?
You said no.
I said no, I mean, wait, hold on.
Just to clarify, if you block the foramen of Luschka or Magendie, that is still obstructed.
Yeah, sorry, I'm sorry if I misspoke, my bad. Okay, let me start from the beginning. Let me restart. I am so sorry. If I block my foramens of Luschka or Magendie, it is obstructed. Regardless of if all of my ventricles blow up, I am so sorry for that misspeak. So any sort of blockage like that in any of my ventricular system is obstructive. I would like to move on by saying the only time that it's non-obstructive is basically arachnoid granules. So you're either making too much or not able to take enough out. So making too much would be choroid plexus, like freaking out and like making a ton. Not ideal because I can't think of any situation where that like actually happens in real life. Or my arachnoid granules, there's a problem there. And we know my arachnoid granules sit in my superior sagittal sinus, right? So let's just say I tear that or something like that. Then I would affect my arachnoid granules, therefore causing non-obstructive hydrocephalus. So any sort of blockage, whether it be cerebral aqueduct, interventricular foramen of Monro, foramen of Magendie, foramen of Luschka, regardless, no matter where on the path, that's going to be obstructive. Does that make sense? I'm really sorry for the...
So the stem could look like, you know, this person is hemorrhaging and they have red blood cells stuck in their foramen of Magendie or Luschka. That would still be obstructive hydrocephalus, even though all of your ventricles would be enlarged as a result of that. The only time it's communicating hydrocephalus is if you are making too much cerebrospinal fluid or you will have trouble reabsorbing it through the arachnoid granulations.
Cool. So CSF, just keep in mind there's like all those things of what CSF is high and low in. CSF is normally low in glucose and protein, particularly. Anytime you see protein in the CSF, you have a problem. Anytime you see WBCs in the CSF, you have a problem. Anytime you see RBCs in the CSF, you have a problem. So protein, WBCs, RBCs, bad. Your spinal tap should be nice and clear, no problem. Make sure you do a little fundoscopy before you start taking CSF out, otherwise you're gonna cause a tonsillar herniation and you will kill your patient instantly. Do not do that. Okay, I don't know why I put that there.
Have you guys learned about the difference between diploic and emissary veins?
Yeah, it's more anatomy, so I'm just gonna put that for a little definition.
Diploic, can I just see that? Yeah. Okay. If you have some kind of like infection in the bone or anything like that, the answer will never be diploic. It will almost always be emissary vein. Just if you can't figure anything out from the stem, just diploic, probably not the answer.
Yeah, I honestly don't remember how those work, so I didn't say anything about them. I don't remember any questions on them. All right, this picture right here. Really important because it's got all my sinuses, so be able to point out everything here. So I'm just going to go through real quick because it doesn't have everything labeled. So right here, superior sagittal sinus, that's where my arachnoid granules are. That means if I tear those, I'm going to have that communicating hydrocephalus. Then I come down to the confluence of sinuses right here, right? So it's going to be a nice big area. And then if I go more anteriorly, straight sinus, I'm going to have my great vein of Galen there, not to be confused with my inferior sagittal, which is you can barely see on this image, so not super high yield. So no, this is straight sinus, and then if I'm more anterior, then that's inferior sagittal. So then I have my transverse sinuses coming out from my confluence, and then I would have my little sigmoid sinus, which is more anatomy, and then that goes down right to my jug. So really superior sagittal is the highest yield there.
This is a very good image to know.
This one?
No.
This one?
Yeah.
This one. Yeah. Know that. Okay, circumventricular organs. I'm not going to talk about all of them. I'm going to talk about two of them. What you need to know, well, you should know all of them, but you know, time is a little bit of a
Money.
crunch now, yeah, time is money. So you need to know your area postrema, and you need to know where it's located. So it's down right here, right? Like I see my pons here, my medulla down here, my midbrain, and my cerebellum. So right on my anterior part of my fourth ventricle, and this is my vomiting center, right? So what's big picture? What's important about circumventricular organs? This is where my blood-brain barrier is pretty loose, right? And I can kind of sample different areas, and I can know where my toxins are, or I can know am I dehydrated, all these different problems. So it's super important. So area postrema is going to test for toxins and things like that, and it's my emetic reflex, which means if all of a sudden there's something toxic in my body, you can like instantly vomit. Another really important one, so that's normally given a lot of attention, but what normally is not is my subfornical organ. So we know that my fornix, we mentioned earlier, right, that connects my mammillary bodies to my hypothalamus. I'm sorry, my mammillary bodies to my hippocampus, and if I lesion that, I have a memory problem. That's just like an aside there. But subfornical, so this is my corpus callosum, this is my fornix right here. So just under the fornix, right by my thalamus, is going to be thirst regulating center. And remember when we learned like ADH? So we're talking in the last term, right, throw it back. ADH in renal, or when you guys are endocrine, whatever, that's my thirst stimulating hormone or whatever. Okay, how does it work? It just magically makes me thirsty? No, it goes to my subcortical organ, and my subcortical organ tells me I'm thirsty. So just be aware of that relationship. It's pretty interesting.
Just another good thing to know is if you have an issue with your midbrain tectum, so like the top of your midbrain, it will affect your pineal gland first. I know a lot of people will be tempted to put cranial nerve, but it's your pineal gland.
So we know that pineal gland is right here, and my tectum is the small part of my midbrain, right? Because tegmentum is a bigger word, which means it's the bigger part of the brainstem. So this is midbrain tegmentum, pons tegmentum, etc. This is going to be midbrain tectum, and she's totally right because my pineal gland is right there. So if this enlarges, it's going to go back and hit that, which we know that's for sleep. Cool. All right. So regulatory. So keep on trucking. Okay. So this was like. Honestly, this was like one of the hardest few lectures for me. I thought they were really disorganized, or like maybe it was me, I don't know. So what's important, I tried to put it in like as least amount of words in what you need to know right here, instead of those like really dense essentials and lectures. So we'll try to just go through this nice and painlessly. So in my midbrain, I have this thing called my periaqueductal gray, which, you know, without even knowing anything, I can know exactly where it is. It completely surrounds my cerebral aqueduct. So if I were to look at my cerebral aqueduct, it would be the area completely around it. So what that's going to be in charge of is pain and a little bit of cardiovascular, but what you need to know is pain. And we'll go into, when we do cell in about, I don't know, like 5 minutes or so, like what kind of controls pain and things like that. So another thing I want to put, like, to say, if you like can't remember anything, remember as you go more inferiorly in your brainstem, things get more vital. What I mean by that, yeah, like pain is really important and, you know, things like that, but what's more important is respiration, right? And respiration is located like in my medulla. It's actually kind of located scattered throughout, but my most important respiration centers are in the caudal part of my medulla, the most inferior part. So just remember that pattern as you go down. You'll have things, you know, like taste, urinary reflex, CV, and then respiratory will always be most inferior. So pons, what's super important for pons is knowing your pontine micturition center is there, and easy to remember that your urinary, sexual, and GI system are all interrelated there, because, you know, those are kind of all like in the same area, I guess. So, I honestly don't have super great ways to remember it, and that's because they're not very high yield. So I tried to make it nice and concise. So pons, no pontine micturition. Midbrain, nociceptive via periaqueductal gray. Medulla, this guy's a little bit way more important, so that's why it's a lot more testable. So I know I have my NTS there, right? My nucleus tractus solitarius. And I know that that's basically my solitary nucleus, which is my nucleus for cranial nerve 10, right? My vagus nerve. And let's just say I'm sitting in my exam and I like totally blank out, and I'm like, oh, I don't remember, like, or solitary nucleus, whatever, go back to your embryo, and I don't know, if like you learn it this way and then you could apply it to embryo or vice versa. I know that cranial nerve 10 is associated with medulla, which means that their nucleus must be in the medulla. So keep all those associations in mind. And like I said before, we have this like pattern. So my solitary nucleus is that like nice long oval shape, and so the top 1/3 is going to be taste, the middle is going to be GI, and the inferior is going to be cardiovascular and respiratory, and we can see that like it's going in increasing importance inferiorly. If this wasn't in your lecture slides, it is an essential objective, so I just kind of want to put that out there. And if you're like, oh my god, I didn't read the essentials and I'm freaking out, it's okay, you've got plenty of time, don't you worry. So now let's talk about, this was definitely in your slides, so let's talk about this. So this is super high yield because it's like a reflex, right? And I think at some point I kind of went into more words, so I'll talk it out here, and I like wrote it out like in the outline at some point. So I have a rostral ventrolateral medullary nucleus and a caudal ventrolateral medullary nucleus, and essentially I like to remember it as my rostral rushes my heart, right? Makes it faster. So it's gonna be my heart pressor is like the weird way they like to say it, and my caudal calms my heart. It's my depressor, right? And then I can kind of extrapolate, okay, if my R rushes my heart, then it must be an excitatory pathway, which then I can extrapolate, okay, well then it's probably going to use glutamate. Did I have to really memorize much of that? No, it's a pattern, and hold on to these things and memorize the exceptions. Don't memorize the things that are normally true, right? So then my caudal is probably going to be GABA, right? Because my GABA is my major inhibitory one. So do I want to talk about this now? We'll go back to this reflex because somewhere, yeah, we'll do it now, whatever, sorry. So if you scroll down on the thing a few hundred pages, so yeah, now I'm on page 24. I just want to like complete this thought. So I'm gonna have it here while I just kind of talk it out. So wait, I know I have two major baroreceptors, right? These are kind of like my pressure receptors. I have one on my aorta, which is gonna be, which cranial nerve? 10, cranial nerve 10, vagus is the big one, vagus is the aorta, which is a big artery, that's kind of how I remember those. And then I have cranial nerve 9 on my carotid, right? So I have a baroreceptor there. So this kind of pathway, 9 and 10 are both, I don't want to confuse things because we know 10 is solitary nucleus, but 9 also will have a synapse there, right? Because it does this baroreceptor reflex, so keep that in mind, that this pattern is for both cranial nerves 9 and 10. So let's just say, for example, I have a fall in my blood pressure. So I should already know if my blood pressure is falling, my body's reaction for homeostasis is going to want to bring it back up. So I already know without even knowing anything that my RBLM is going to be activated, but let's go through the pathway. So my blood pressure falls, which means I have less pressure in my, let's say, vagus, so let's pressure my aorta. So I'm going to have less firing of these receptors. So what's going to happen is this information is going to be transferred to my NTS, right? And that's in my medulla. So then my NTS is going to communicate with my RBLM because that's also my medulla. They're literally like right next to each other. So my RBLM then is going to have a glutaminergic response and send a signal to my sympathetics, right? Because my RBLM can't do too much like on its own. It doesn't directly innervate the heart. What it can do is drop down to sympathetics, which remember is T1 to L2, right? So it has to drop down quite a bit, right? It has to go all the way through my cervical spine and tell probably about like T1, T2, okay, increase firing, increase sympathetic firing, and then that's how I get my heart to pump more. Does that make sense? So I need to, RBLM essentially, in short words, stimulates sympathetics. So now what's super easy is CVLM. All CVLM does is give GABA to RBLM. So what that means is, my caudal VLM doesn't really go to the heart, right? It's not gonna like give GABA to the heart and say slow down. All it's gonna do is tell my rostral VLM, stop giving so much glutamate. I don't know how to say that in like simpler words, so I kind of just put it here. So if my blood pressure gets too high, all I'm going to do is tell my rostral ventrolateral medulla, stop stimulating sympathetics via my CVLM. Yeah.
Do you guys remember back in physio when you guys learned about sympathetic control? So there's no parasympathetic control of your vasculature. You just stop applying sympathetics. Does that make sense?
Yeah,
So
so
it's kind of like the
concept
same
there.
idea here.
Cool, so then ventromedial, we have raphe nucleus, which is serotonin. Honestly, I don't think those are high yield. What's really important are these right there. Out of all that nonsense, if you can remember these guys, you're in good shape. Cool, hypothalamus, just don't forget like your endocrine BS, your prolactinoma is gonna, hit your cranial nerve too, right? It's gonna hit the optic chiasm, all that good stuff, so I'm not gonna go into that. What you need to know are your nuclei of your hypothalamus. So I'm gonna briefly speak about this. So easy way to remember them, right? So I have a ventromedial nucleus and a lateral nucleus of my hypothalamus, and I know my lateral nucleus makes me get larger, right? Because it's my feeding one. So when my lateral nucleus is stimulated, it's going to make me eat more and increase feeding behavior. While my ventromedial nucleus, which is going to be medial, right, nice and small, that's going to suppress feeding behavior. Nice and easy to remember. Okay, this body temperature one. So I like to remember my aim. So we know hypothalamus, big picture, is my regulatory system. So that's why it's in charge of feeding, body temperature, all that good stuff. So my anterior, I like to think of it as my AC. So my AC cools me down, right? Decreases my body temperature. And my posterior is going to increase body temperature. What this means is that when I'm hot and I'm sweating, right? My anterior hypothalamus is on full blast, right? So sweating is to decrease body temperature, and I know some people like that might not be as intuitive, but in hot situations you're going to want to decrease. So sweating is anterior hypothalamus controlled, as well as shivering is going to be posterior hypothalamus controlled, right? Because that's to increase body temperature. Okay, this little thing right here. If you gotta memorize a cold, just memorize it. It's one of those things that has been passed through the semesters, and I have argued it myself. But if you were to take out your anterior hypothalamus, put it on a petri dish, put some cold water on it, what's gonna happen? The answer is hyperthermia. And essentially what they're getting at here is you're suppressing your anterior nucleus. What's gonna happen? Your posterior nucleus is going to take over and make you shiver, giving you hyperthermia because you're increasing body temperature when it's not necessary. I'm not gonna say that's coma, but maybe it has, One last thing, ventromedial, which we know is like the nuclei that suppresses feeding behavior. This can sometimes be lesioned, right? And that's going to be Frolic syndrome. Frolic syndrome, let's just say I'm like not even reading this paragraph. Well, I can already assume if my medial nucleus isn't working, then my lateral is going to be on hyperdrive, which means these people who are inflicted with this lesion are basically just constantly eating and they never are satisfied. So just kind of be aware of that. It's a very interesting syndrome.
Are you not gonna?
Diabetes insipidus? Oh, you guys know this from endocrine. I'm not gonna go through that.
Well, the way the patient will present is like somebody will have a car accident, they hit their head, and all of a sudden they're producing very dilated central diabetes insipidus.
Okay, so pupil, I'm not going to go into pupil that much because I'm sure you've done it 400 times. One thing I want to note is this little pathway right here, my hypothalamospinal fibers. What that is essentially, so you guys know the parasympathetics, cranial nerve 3, blah, 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 you all know that shit, Edinburgh, Westfall, whatever. What's important though is sympathetics. So we know my sympathetics, like, for some reason, it's just so easy to forget that these are located in my thoracic spine, my thoracic spinal nerves, right? Which means that to communicate with them, I need to go down, which means I need to use my hypothalamospinal fibers, which means, okay, like what does this mean to me? This means that any lesion, whether it be midbrain, pons, medulla, if I were to just like completely dissect it or whatever, then I'm going to lose my sympathetic innervation. Because I know like for midbrain, yeah, if you lesion the midbrain, you lose parasympathetics because that's where the nuclei and cranial nerve are located. But if I were to lesion the pons and say, okay, what's going to happen to the eye now? Well, a lot of people are going to be like, huh? What? Like, what's that going to do with it? And you guys are going to know, oh, well, that's going to affect my sympathetics, right? Because my sympathetics have to travel from hypothalamus all the way down to T1. So that's kind of all I have to say about that. Okay, bladder. So rumor has it you guys didn't learn about spinal shock, so this becomes much easier to teach this concept. So Pontine micturition center, I just wanted to bring that up. Remember, midbrain was periaqueductal gray, has to do with nociception. Pons says Pontine micturition center, so that's where we can have issues with our bladder. Blah, blah, blah. I'm not going to go into this too much because I'm sure that you've talked about it a lot. One thing that I really want to note, though, is that it's really, really rare to have a lesion to S2 through S4, right? So I know S2 through S4 innervate my bladder and things like that. But like, how could I damage my sacral nerves? Like maybe if I like completely get into this wild car accident and damage my sacrum. But what's more high yield is damage to my conus medullaris, right? And we know my conus is located around like L2 area, right? L1, L2 depends on the person. And that's where all of the nerve cell bodies are located for L1, L2 on, right? All the way to my coccygeal nerve. So that's much more likely to be lesioned. So don't get tripped up if they say damage to conus, or have that as an answer choice and be thinking L1, L2. No, you need to be thinking L1 all the way down to coccygeal. And that's where you can get an atonic bladder. And know that an atonic bladder is way more medically dangerous than automatic. So automatic, yeah, like it really sucks for the person. But atonic bladder like could explode and have your patient go into sepsis. One other note I want to add on to that is atonic bladder, how it presents is dribbling of urine. Dribbling of urine, and it's like, oh, well, that's kind of weird because, like, how are they urinating if, like, they're not urinating, right? What's happening is the pressure in the bladder gets so large that it forces the internal and external sphincters open, right? So you get these little, like, droplets of urine. It's not a full stream. In automatic bladder, it's a full stream of urine, like, they're constantly urinating. In atonic, dribbling. And, of course, like, the distended suprapubic area, things like that. Heart, okay, yeah, so we just did this, so like all of this words, I tried to like describe this and probably like worse than they described it, but I tried. Okay, respiratory centers. So there's this mnemonic, it's RICE, R-I-C-E. So big picture, we're talking about medulla because we're talking about respiratory. I'm a big picture kind of person, so I try to always step back and be like, okay, what am I talking about before I get lost in the details? So RICE basically means that the rostral part of my ventral respiratory column is going to be in charge of inspiration, and my caudal part is going to be in charge of expiration. Do you need to know much more than that? No, thank God. So if you know that, other than, oh, okay, this little guy's a little bit important. So my pre-Botzinger complex. I don't know who names these things. They name them after themselves and make it hard for us. So the pre-Botzinger complex, literally, if you can just remember like respiratory rhythm, pre-Botzinger. To me, like pre-Botzinger sounds like a singer, right? A singer has to keep rhythm. So that's kind of how I remember that. And yeah, that's as long as you know RICE and pre-Botzinger, you'll be pretty good there. Okay, so this picture, like I showed this on my DS and everyone was like, what is happening? So I'll briefly describe this because this is in Essentials and it's not in the lecture notes and it wasn't in our lecture notes either. So that's like what I want to put out there is it's not like your lecture notes are missing things, like ours didn't have any of this information on it either, but we were provided the essentials. And we are providing you guys with the essentials. So email who you want about that. I'm definitely gonna contact them, by the way, because that's like not really nice. So essentially what this is respiratory rhythms that would occur with different lesions along the brain and brainstem. So this right here is Shane-Stokes respiration, and remember that is a cortex lesion. So a cortex lesion will give me Shane-Stokes, CNC. And what happens is they don't breathe and then they hyperventilate for a second, they don't breathe, hyperventilate. Midbrain constant hyperventilation. Do you have to know like why this happens? No, right? Because all we know is like respiratory centers are in the medulla, right? Know that and then just kind of keep this in your pocket. We were asked these, like, I'm sorry. So PONS, like just describing this, so this is going to be hyperventilation. PONS is apneusis, and essentially what that means is they don't breathe. They inspire and they hold the inspiration, and then they expire and they hold the expiration, and then they inspire and they hold the inspiration. And as you can see, these are getting more and more intense in their deficit as we kind of decrease down the brainstem, which makes sense, right? Because things are going to be more dramatic and change as we go down. So then, in my lower pons upper medulla area, normally they'll say like upper medulla, I have this ataxic breathing. Essentially, ataxic is like no rhythm at all. Like it's going wild. So they can make that line look however they want. So like no breathing, a little bit crazy, nothing like. So it's just very awkward looking line. And then if I lesion the most inferior bilateral parts of my medulla, well, I'm in respiratory arrest. I'm not breathing at all, right? So keep that in mind, that things get more intense as they go down. Remember this word, Shane-Stokes. Okay, so we're gonna move on to cell. I'm debating if I want, no, we'll just keep this running through. Okay, so I'm probably gonna move a little bit fast because there's not too much that's super testable. One thing I want to say is there's like this mnemonic that we use, Dr. AK. You guys can use however you want, but just knowing that like diamine is retrograde, anterograde is kinesin. I know you've heard it a million times, don't forget it comes up. What's more important is knowing that these are microtubules, because they can make a combo question saying like, oh, what kind of transport is this? Microfilament diamine, microtubule diamine, you know, like things like that. So we know that microfilaments are more like with structure and actin, and my intermediate filaments and those all work together, but my microtubules are in charge of transport, right? Tubules do transport, and that's gonna be diamine and kinesin. And know that these are ATPase moderated. No, like, I mean, this is histo, but you know, your multipolar, bipolar, pseudo-unipolar, multipolar is going to be motor, bipolar special senses, pseudo-unipolar is going to be somatosensory. Class A, I am so sorry, I know I'm rambling, and are you guys okay? You guys are good? Okay, cool, sorry. All right, so we have Class A, Class C, and then we'll talk about like Class 1, 2, 3, 4. So essentially these are like different systems, so you describe a nerve as like either Class A, Class C, and then Class 1, 2, 3, 4. And what's pretty cool is Class A and Class C, all that's talking about is am I myelinated or not? And we know that most nerves are myelinated, right? So those are gonna be categorized as Class A. So my unmyelinated fibers are gonna be categorized as Class C, right? And then I have Class 1 through 4, right? And those are based on speed. And I know that speed is super interrelated with myelin, right? So my Class 4, which is my slowest conducting nerves, are going to be Class C as well. So if you see 4, you can say C. And what else you could say about these are that these are my pain fibers, right? Because let me give you an example. You touch a hot stove. So we know that pain temperature are kind of the same pathway. So I touch a hot stove. I feel the stove first. Like I physically feel it before I feel the heat, right? When I stubbed my toe, I physically felt that I touched something before I feel the pain. And that's because of these fibers, right? They're unmyelinated, they're slow, takes a little bit more time to get there. So Class C, Class 4 pain fibers are all under the same subgroup. And Class 1 are gonna be the most rapid and then on the way down. So that's kind of the only correlate you need to make about that. I'm gonna talk about this later, so I'll keep going. Okay, so regeneration. Okay, so let's talk about degen before I talk about regen real quick. So, let's just talk about regeneration. So regeneration, essentially, all you need to know is PNS regenerates way faster and much more than CNS, right? So that would be like if I have like a peripheral nerve lesion versus getting like stabbed in the spinal cord. And I know that sounds really, really simple, but they can word the question very interestingly with that. I honestly can't come up with it off the top of my head. But that's what, like a thing that I was saying, like if it doesn't make sense like right off the bat, like read it again, because literally they're just asking peripheral or central nerve lesion, and you know that which one of these is not like the others, right? So it's gonna be the peripheral nerve lesion. So, degeneration. I want to talk about anterograde versus Wallerian versus retrograde. So essentially how, I wish I would have drawn this, but you have like, let's just say 3 nerves in a row, right? You have your normal nerve, and then your presynaptic, and then your postsynaptic. Actually, let's do this. So I have my nerve here. Can you guys see this? Cool. So I got a nerve here, a nerve here, a nerve here. I went to art school before med school, if anyone tell. So let's just say I mess this guy up, right? So what's gonna happen, and is it always chronological? Not so much, but it kind of helps me to think of it that way, is the nerve itself is gonna degenerate first, right? So what's gonna happen is this axon is gonna degenerate, and what that is called is Wallerian degeneration. So Wallerian is localized to just that same nerve. I cannot emphasize this enough. Wallerian degeneration is the same nerve degenerating. It is not the nerve, the postsynaptic, it is not the presynaptic, it does not include those, it's just itself. So Wallerian is itself. Then, what, either one or the other, it doesn't really matter. If it affects the postsynaptic nerve, this is gonna be anterograde. So even though it looked like it was moving forward, right? We went from cell body to axon, whatever, degenerating that, it's not anterograde, that's Wallerian. As soon as it hits this one, well, now we know that this is Anterograde. Cool. And then, of course, retrograde is easy. As soon as it hits the presynaptic, that's going to be retrograde. Does that make sense? Cool. This is just in general.
All nerves.
All nerves. Okay, length constant. Are you going to have to calculate length constant? No. You need to know conceptually what's going to increase it and decrease it. So length constant in words, conceptually, all it means is that, so I'm not talking about action potentials here, right? Because I know action potentials are all or none, and once they start, they're not going to stop, right? This is just like a graded potential. So this is like an initial stimulus. How far is it going to get before it reaches 37% of its initial conduction? And what's going to increase this, which essentially means what's going to allow it to propagate further before hitting that 37%, is increasing the membrane resistance. So essentially what that is going to be myelin, right? So we know that myelin is this really dense, big protein that sits on the outside, right? And that increases the resistance. And when we increase membrane resistance, we force our transmission to jump, right? And we have saltatory conduction. Flip this. If I were to increase my cytoplasmic resistance, which the common example of this is literally increasing the diameter of my axon, so not increasing it via myelin, but like the actual cell being larger, that's going to cause a decrease in my length constant. So I'll say this in another way. So you increase length constant by increasing membrane resistance or decreasing intracellular resistance. If you want to like read it in regular words, I think it's like right there. So again, cytoplasmic resistance is based on literally the size of the axon, like the cell itself. And membrane resistance is the myelin.
If you, damn it. I don't think this thing is working. Hello? Hello? Yeah. This is so awkward. Okay.
Oh, get close to me, Ruby.
Okay.
I've been waiting my whole life for
So if you
this.
want to think about it like a vessel, so if I have a larger space for things to bounce around in, the signal is obviously going to travel much slower than if I make the cell smaller or I increase resistance on the outside, and then my signal is going to go straight across. Does that make sense? So if I want to increase my length constant, I have to decrease membrane or cell resistance, increase membrane resistance. Cool?
Cool. Let's run it back one more time. Someone say that? Yeah, sure. So what you were saying is compare it to like vasculature. So we know that if I have like a larger vasculature, it's going to be more turbulent, right? Because it's going to bounce all around. But if I have like smaller vasculature, it's more of a straight shot. And that's an easy way to remember that if you increase the cell size, it'll have increased resistance, which decreases my length constant. Cool?
What? Resistance of the cytoplasm. No, we said it right. Resistance of the cytoplasm increases inversely with the cross-section of the area.
Yeah, so the diameter of the axon is probably including the myelin.
It says larger diameter.
Okay.
Like the vessel being
Like,
All right, so we will come back to this and I'll say it more concisely. How about that? Everyone just like do that little like erase your memory if I said it wrong. I completely apologize. My bad. Sorry. Okay, so let me re-say this. How about that? So my length constant, so let's kind of just go over it like this. If I increase the electrical resistance of my membrane, it's going to increase my length constant, right? We're all on board with that one. Yeah. And then if my cytoplasmic resistance increases, okay, you know what? I'm just gonna move on because I'm just like reading and you guys can read it and I'm sure you all like got it on your own. So we'll go back to this. I sincerely apologize. Okay, so impulses propagate without decrement. So essentially this was just talking about our action potentials. Okay, so what I wanted to say about this is that they can have like a picture of a cell, So like it'll be like either multipolar or pseudo-unipolar, and they'll say essentially like where's the trigger zone, like where is the initiation zone, and essentially what they're asking is, do you know the difference between where things start in motor versus where they start in sensory? So in motor, the axon hillock, which we know is like this guy right here. So if they draw it like this, so we have this right here. If this is a motor fiber, this is our initiation zone, right? Like where my axon begins. As opposed to pseudo-unipolar, which is going to look like this, right? Let's just say like this is my CNS, right? My motor is located in my CNS. And I've got these guys there, and then this is like my DRG right there. So this is my pseudo-unipolar. It's going to go all the way out, right? Give all my little dendrites there. This is going to be my initiation zone. So keep that in mind. So note that the initiation zone is going to be distal to the cell bodies in pseudo-unipolar and bipolar, as opposed to multipolar, which is going to be at the axon hillock. Okay, distribution of voltage-gated channels. All I want to say about this is myelin has a really big part in how our impulses propagate, not by just allowing self-destroyed conduction, but literally where the nodes are located. And it's this nice little tiny detail right here that says my sodium channels are located in the node, which makes sense, right? Because my sodium channels are really important for conduction, and those are going to be located like exactly in the node. And my potassium are going to be paranodal, so just lateral to each of those. So I would have potassium in this like blue area, and then I would have sodium in this dark area, as opposed to an unmyelinated axon that has either of them just scattered throughout. So keep that in mind, and that's what allows our impulses to conduct much more efficiently. Local anesthetic, all I want to say, lidocaine blocks sodium channels. Just know that. Okay. Oh, this is quantal content stuff. Okay, so quantal content versus quantal size. Okay, so these are like two, all right, rewind. So we have neurotransmitters, right? We don't just like constantly release neurotransmitters. We have to release them in kind of vesicles, right? And we release them out. So we have quantal size, right? My quantal size is like how much neurotransmitter I fit per vesicle. I'll give you a way to remember this by telling you what quantal content is. That's how I do it. I remember that one, and so I know what quantal size is. So quantal size, you can't really like change, is what I want to get with that. And because you can't really change it, and because you can't change it, that means it's not very testable, right? Because like neurons kind of have their set amount of neurotransmitter that they're going to release in each vesicle. What you can affect is quantal content. And quantal content is the count of vesicles, like 1, 2, 3, 4. Quantal content is the count. So you can affect that, right, by different blockers, right? So if I were to give like a calcium blocker, and I would say, how would this affect my cell? Well, I would say it would decrease quantal content, right? It would decrease the amount of neurotransmitter released, which I could say by decreasing the amount of vesicles released. It won't affect quantal size. I can't think of anything that affects quantal size. Not even one thing. But quantal content is easily affected by any of our blockers. So axodendritic, axoaxonic, essentially I like to think of, so this is like, is the impulse excitatory, is it inhibitory? I like to think of this as like a race. And we know like my dendrites are like my starting line, my axon is my finish line, right? So when I start the race, it's excitatory, right? So my dendrite is going to be an excitatory synapse. You tell your cell, okay, make your neurotransmitters release and go do your thing. But then as you're approaching the finish line, like if it's a competition, you want to stop everyone around you. So you hit another axon, that's going to be inhibitory, right? So axodendritic is going to be excitatory synapse, axoaxonic inhibitory. So they could give this to you more like conceptually, like remember how we were just talking about RVLM and CVLM? And we know that CVLM inhibits RVLM, right? Because it's right my caudal, ventrolateral medulla. We're talking about heart homeostasis and blood pressure and things like that. So I could say, what kind of synapse is this? Well, first you would need to know that CVLM inhibits RVLM, and then you need to know that's going to be an axoaxonic synapse. Axosomatic is not really tested, but they wouldn't put like axoaxonic and axosomatic together because they're both inhibitory. I put this in here. It's not really important, actually. I don't know why I did that. Oh, this is why. So we have like our vesicles, right, that contain our neurotransmitters, And like, let's just say dopamine, for example, you gotta like load up the vesicle before you let it out, and it's normally through a hydrogen exchange pump. So keep that in mind, because they'll just put like a ton of other like little electrolytes. They'll say like what, like sodium, calcium, blah blah blah. So you know it's a hydrogen antiporter is what you can say.
Can I go back to the thingy?
Okay, so this snare protein stuff like this is more important when it comes to things that can mess with it. So I'm gonna leave this here. They'll never test it like this. They're gonna test it in things like botulism or tetanus or something that can mess this up. Make sense? So they'll never say like this. Okay, so I actually talked about this. So this is just talking about the quantile count and size. Okay, so I want to talk about like conceptually what mini EPP versus EPP is. Okay, let me move a little bit. So essentially, an EPP, so electrical end plate potential. I'm sorry. So an end plate potential is like intentional, right? Like it's a release of a ton of vesicles to create a response, right? To create an effect. A mini EPP is normally like an accident. So you know this body isn't like super regulated to the point where like neurons aren't, you know, releasing these little things. So like how I can say this is a mini EPP has a quantile content of 1. It is 1 vesicle that's released. And what I can say is the strength of what I'm trying to achieve is how many mini EPPs add up to 1 EPP. So you can kind of just use these words interchangeably, like mini EPP is 1 vesicle, 1 quantile content, 1 quantile count. So keep that in mind. Is there anything else? Oh yeah, so this, I tried to use that that calcium example, like you block the calcium, what's it gonna affect? And it would decrease quantum content. Okay, toxins. I can't like teach you these, but these are the ones that are high yield. So you know that like botulism, cleves and abdobrevin, I mean, these are kind of things. I just wanted to keep them on here to jog your memory. Know that tetanus uses retrograde transport, which means it uses diamine, which means it uses microtubules, because that's how they can make that question harder, is essentially just not being like, oh, what's retrograde transport? They could say, tetanus, what does it use? And then you would have to know it does all this. But what it does is you would think, okay, well, if it blocks, so it's gonna jump on my motor neuron, right, and travel back. But it doesn't affect that motor neuron itself. What it's gonna do is it's gonna jump to an interneuron. And we know that my interneurons are in charge of kind of like inhibiting things, like quieting things down, because normally things that are excitatory are like really excitatory. So we need some sort of inhibitory calming factor. That's what they call it, inhibitory neurons, like calming neurons. And those release glycine. So we know that GABA and glycine are my major inhibitory neurotransmitters. So it's gonna jump to this inhibitory, oh, you know we're in here. No.
Ralph? Thank you. Just while we're turning on the lights, what's the name of those glycinergic interneurons in the spinal cord?
Oh, good question.
Somebody say it real loud. Renshaw cells. So Renshaw cells are the glycinergic interneurons in the spinal cord. Renshaw cells. They
Yes.
might ask something like that on your exam.
Yeah, so what they could say, if they haven't said it to you in lecture, then maybe they didn't bring it up. But what they do is they jump to these inhibitory interneurons, also called Renshaw, just like that, Renshaw cells. And they inhibit the Renshaw cells. So that prevents the glycine release, causing the tetany. And keep in mind, tetany, sorry, can you guys hear me? Tetany is not always tetanus. Does that make sense? Tetany is used to describe like a muscle contraction. So tetanus causes tetany. Tetany is not always tetanus. These were mentioned in the essentials. May come up. So I just, honestly, this one, I kind of always just take the L on this, and I just remember, like, this is the one I don't remember. But I know that aminopyridine has that little P in there, unlike tetanus and botulism and stuff like that, so that's going to affect potassium. So aminopyridine affects my potassium, and my potassium and calcium have this like really weird inverse relationship where if I block potassium, that increases calcium. So something to note here is that 3 of these 4 toxins, so botulism, tetanus, aminoglycoside, these are gonna normally like block things, right? So we blocked glycine, we blocked acetylcholine, we blocked calcium. Here, we're blocking potassium, which increases calcium. So this is one of those situations where now we increase quantal count. What the heck? I don't know what I was trying to say there. So we're going to increase the quantal count here by increasing calcium. So aminopyridine blocks potassium, P for potassium, potassium, calcium, inverse relationship. Cool. So these were the, okay, so you know how like in the cell, like neurotransmitter lecture, there was like all those projections and like all that craziness? Okay, like you don't have to know all that. All you need to know are the nuclei of where it came from. Because where it goes is like everywhere. Like acetylcholine's like everywhere. So we need to know where it starts from. So I tried to like make it nice and condensed. And so we know acetylcholine is the basal four-ring nucleus of Maynard. And another key thing, so it doesn't really matter for most of them other than like epi, norepi. So this is synthesized in the cytosol. Most of them are until we get to norepi and epi. So I'll talk about that then. And you guys know that, nicotinic and muscarinic receptors. Glutamate, just know there's two ways to get glutamate. It's either through the Krebs cycle, right, the TCA cycle, or recycling. And we'll talk about recycling real quick. So we have these things called tripartite synapses, tripartite. And what that means is there's 3 cells involved. So this third, so we know it's like, presynaptic and postsynaptic, but this guy right here is my astrocyte, right? And my astrocyte is involved in this thing called spatial buffering. And all that means is that it can like pick up potassium and like siphon certain things, so it just like cleans things up. But what it can also do is pull some of this glutamate. You don't really need to know all the details, just know that it's involved, and it'll spit it back out and recycle it. So the ones that were left over in the synaptic cleft, it'll pull it out, bring it right back to presynaptic. So just know either the presynaptic cell can make some more glutamate via TCA, or it can have it recycled via this guy right here, spitting it back out from postsynaptic to presynaptic. We talked about tripartite. I like how I leave myself a nice talk about NMDA. Okay, so we'll do that. So glutamate is really important because of the receptors. There is the major ionotropic receptors. Honestly, AMPA and NMDA are really, really important. Metabotropic are not so much, right? They're my EMBLers. But let's talk about AMPA and NMDA. So AMPA is nice and easy, right? Like we let sodium in, we push potassium out. But NMDA is a little bit more complicated, so let's talk about it. So this is a glutamate receptor, right? So glutamate's gonna bind, and what it also needs is glycine to bind. So NMDA won't work unless glutamate and glycine both bind. You don't need to know like how the glycine gets there, just know that that's there. And in really small words, and I think that I found it on your slide as well because I wanted to confirm, is that glycine is inhibited by strychnine. And it says it in really tiny letters right there. So glycine is inhibited by strychnine. There are just 2 particles that are about the same size, competitive inhibition, which means that strychnine can inhibit NMDA, right? Because I need that secondary binding, right? So if strychnine binds in that glycine area, then NMDA won't work as well.
Yeah, that's exactly what I was going to say.
Oh,
It's a strychnine insensitive glycine binding cell.
Okay, I am so sorry, guys. So strychnine does inhibit glycine, and this specific site, I'm so sorry, is strychnine insensitive, which it says right there. So just keep it in mind that when we talk about the glycine receptors, strychnine can affect those, which we talked about with our inhibitory interneurons, the Renshaw cells. One last thing I want to say about NMDA is that there's this magnesium ball and chain right down in here. So what that means is magnesium like sits inside of the receptor, and for the receptor to open up and allow that efflux of ions and influx of ions, whatever it's got to do, this magnesium needs to move. And normally, we know magnesium is positively charged, right? So normally how we get this to move is via AMPA receptors open first, and NMDA are a little bit delayed. Doesn't really matter too much now, but you guys did that like memory little tidbit, right, where we learned about like phosphorylation and increasing the AMPA receptors and all of those things. That's where this matters. So like right here it doesn't really matter too much, but there it's going to matter because first you need AMPA to work, then NMDA will work, and then that will affect AMPA. So keep that in mind that the magnesium is there blocking because they can make something as simple as which ion blocks the NMDA receptors.
This is how we form memories. So long-term potentiation just means you have at first a small stimulus that then gets bigger as you have more stimuli. So first you read something once, but then you read it again and again and you remember it. So the most important part of long-term potentiation is that you need to have glutamate bind to AMPA first so that you can depolarize the membrane, kick magnesium out of the NMDA receptor so you can allow, it's a non-specific cation channel. So potassium is going to come out, sodium is going to come in, calcium is going to come in, and then you're going to phosphorylate these AMPA channels so that they can come to the surface and have more do you get what I'm saying? More glutamate binds, more stimulus. Does that make sense to everyone? Cool?
Cool, and we'll talk about that in a little bit more. So GABA, again, made in the cytosol. Really what you need to get from this is that barbiturates and benzos work on this. They increase GABA. So know kind of that there's two different receptors. Both have the same end goal is inhibitory, right? So one is going to be permeable to chloride, which is going to be a negative ion, obviously, right, and decrease membrane charge. And then we have GABA B, which increases potassium. And again, we know that potassium, calcium have that inverse relationship, so that will decrease calcium permeability. Okay, so all I wanted to say about this, you guys didn't really learn about epi, which is super cool because epinephrine is really kind of weird to remember, but you did learn about norepinephrine. And essentially how you guys had these in your slides are just those images, right, of how it's synthesized in the neuron and then moves down. So what they like to do is just ask those little details on those images, but literally all you need to remember is that the catecholamines, we know we synthesize them kind of from each other, right? So what happens is I'm in the cytosol, I make dopamine, and if it's a dopaminergic neuron, I load the dopamine in the vesicle, do my thing. Let's just say I'm a noradrenergic neuron, right? So I'm going to get my dopamine still loaded in the vesicle, and my norepi is made within the vesicle. So how I can make a question about this is saying, where's my enzyme located for norepi synthesis? And that's dopamine beta hydroxylase, right? And that's going to be located within those vesicles. Does that make sense? So if you guys, for some reason I didn't include those images, but dopamine synthesized in the cytosol, then we put it in the vesicle, then in the vesicle it becomes norepi via dopamine beta hydroxylase. And epi, I looked at your slides this morning, you guys didn't have that, which is cool. Dopamine, the nucleus was substantia nigra pars compacta. Don't worry about the projections, just know the nuclei. So these are the three that are possibly asked. Normally it's substantia nigra pars compacta, but still no ventral tegmentum and hypothalamic arcuate nuclei. So then we have norepi, which is locus ceruleus, and then serotonin, which is raphe, and that's all you need to really know about those two, which is cool. Okay, so we're almost done with cell, and then we'll get to sensory. So we have opioids, right? And essentially they're natural opioids, and these are things have you heard of runner's high and things like that? This is what they're talking about. They're talking about making beta endorphins and enkephalin, things like that. Essentially, these are just
Put up the image.
oh yeah, this guy. Yeah, so this is the conceptual part of it. But in your slides, they had these different receptors. We didn't get tested on them. I don't know. It's kind of a weird concept. Long story short, you just need to know that the opioids, beta endorphins and enkephalin, they make you feel good. But
They make you feel good. They make you feel good.
Sorry. They make you feel good. Your beta endorphins and things like that. As opposed to something like substance P. P standing for pain, right? So substance P is synthesized by my unmyelinated class C4 neuron, which we talked about, right? So let's just talk about kind of a situation. So this is a sensory neuron here. And let's just say I feel some sort of pain, right? So this is going to be my unmyelinated neuron. And what's going to happen here is this guy right here is going to release substance P, right, onto my higher order neuron. So don't think of this as your regular sensory system. This is ALS we're talking about here, right? We're talking about pain. So what happens is this guy releases substance P onto this guy. So we know that another word for ALS track is spinothalamic. So that's how I know we're talking about pain here. And it's going to keep releasing substance P, which is going to keep hurting me. So eventually, my cortex is going to be oh, we want this to stop happening. Let's synthesize something that will stop it. And what's going to happen is we know that norepi, right? That's what's going to happen in sympathetics, and stimulated by that, that makes you like less inclined to feel pain. So norepi, which comes from which area? It's going to come from locus ceruleus, right? So locus ceruleus nucleus is going to release norepi, bring that down. At the same time, my raphe nucleus is going to release serotonin, bring that down, and they're going to stimulate this interneuron containing enkephalin. So we know that it could either release enkephalin or beta endorphins, right? Both of them are going to have the same impact, but here we have enkephalin. So this interneuron is then going to release that, which is going to be an axonic synapse, right? Because it's going to synapse on this guy right here and tell it to stop releasing substance P. Does that make sense? So it's an inhibitory synapse using enkephalin onto this axon, saying stop releasing substance P, stop making me feel pain. So another way I can ask this is more of an indirect question, like what indirectly inhibits substance P? So that would be serotonin and norepi, and the direct one would be enkephalin. Okay, so let's talk about some charts real quick. Okay, this is all BS. These are what you gotta know. These two right here. Everything that's on the line is normal and cool and easy to understand, because essentially what this is saying right here is what is lipid soluble and what is found in concentration in my brain, right? Or like what easily passes the blood-brain barrier. So things that don't easily pass the blood-brain barrier down here are not found in high concentrations, and things that easily pass are found in high concentrations, like nicotine. Then we got these two things that are not supposed to pass, but pass pretty easily. So this is like the level of how much it should pass, and this is the level of the, how much it's found in the brain. So essentially all this is saying is what has a channel, like what has some sort of system that I can pump it in past my blood-brain barrier. And we know that glucose, we have our GLUT1, right? And then DOPA, I have certain receptors for that. So they could point to one of these with this blank and say, what should be here? Okay, this guy right here, I'm not gonna go into it because it's kind of just straight up memorization, but what I wanted to say was protein is increased in every lesion here, right? So keep that in mind. And then something to differentiate, please know your differences between your meningitis. So viral is gonna have normal glucose, right? Because viruses are not living, they don't need to use that glucose. Bacterial meningitis will have decreased glucose. You'll also see different WBCs, right? And we know that from histo. So bacterial is gonna be neutrophils. So PMNs are another word for neutrophils, polymorphonuclear leukocytes. And viral is going to have lymphocytes. So keep that in mind. Guillain-Barré, we know that that's my demyelinating disease, and that's going to have really increased protein compared to everything else because you're literally stripping off the myelin.
Did we learn about memory and amnesias and seizures?
Yes. You guys did this, right? Memory, amnesia, seizures? Yeah, okay, yeah, that's okay. So I'm gonna try to make it nice and light. So essentially, that's pretty straightforward. You can either just like not encode the engram or whatever. So we know an engram is a memory. So the key things to this pathway, you're gonna get a whole lecture on it later on. And I know that like we say that with everything, and it sucks when you get tested on like before you actually really know it. But glutamate is the major guy in this pathway. That's something to keep in mind. This is a glutaminergic pathway. So this, I kind of wrote it in like as straightforward words as I could choose, but all you really need to know is that this is a nice big circle. So it's gonna kind of stimulate each other. So we start, I'll try to put the words and this all together. So we're talking about memory and long-term potentiation. So we're located basically in the hippocampus right now. And we're going to start in the entorhinal cortex, which is right down here. And all we do is we jump to the dentate, we go to CA3, we go to CA1, we go to entorhinal cortex. They made it very complicated. That's what you got to know right now, though. So you know you start here, you go to dentate, CA3, CA1, back to entorhinal cortex. So honestly, the most important link to know about this is that you go from CA1 back to entorhinal cortex. So it's finished to start, and then you do the circle again. This little note, I don't think you need to know that yet. So this is just saying that like memories can also be linked to different like homeostatic and sensory mechanisms and things like that. It's in the essentials, but we weren't really tested on that. So just know like the order. I would say know the order and know that it's a cycle and not a linear pathway.
Marissa,
Yes.
do you have to know forming new memories versus pulling old memories?
Not yet. I would say not yet because you're going to have like a whole lecture on that. And they like to test things like, are you going to get any motor on this? Yeah, maybe like one question of knowing that motor is in like the ventral horn of the spinal cord. Just like, will they ask something intense question about memory? Not yet, They're normally pretty nice like that. So yeah, that's why I would say do that. Know that it's like AMPA regulated. Know that glutamate's involved. Don't like worry too much about it. What you should know is this thing right here. So it's knowing like the phosphorylated versus dephosphorylated. Don't overthink it. Memorize what's happening in the hippocampus, and then just know in the cerebellum, like the opposite is happening. So, cerebellum does memory? Yes, who would have known? I thought it was just motor, and then we got smacked with this, and I was like, wow, that's weird. And honestly, we don't really know the mechanisms behind it, so that's why it's not really testable. So in the hippocampus, you have GLUR1, and it's easy to remember that because hippocampus is number one in memory. That's the first one you think of. You don't really think of cerebellum when you're talking about memory. And we know that LTP, which is long-term potentiation, is going to be phosphorylated. Associate those together. LTP, phosphorylated hippocampus. Make those all kind of go together with all of those P's. LTP, phosphorylation, hippocampus. And then of course I know the opposite, dephosphorylation will be LTD. Cerebellum is the opposite. Cerebellum is not highly tested. Keep it in mind that it's like this though, that it's kind of this opposite thing. But like really, like in science and medicine, we don't know how that really works too well as far as I know, or how we were taught. Okay, epilepsies. I just kind of wanted to bring this up to go through the images. So we know that essentially like, what's really important is knowing that in generalized epilepsy, they're unconscious, which is super important when you're talking about absence seizures, because absence seizures will give you this little spikes and waves, which is really important to know what this looks like. So you get these spikes and waves, and normally what will happen is sometimes they can happen like every 30 minutes, and you'll just have this kid who's doing really poorly in school, and that's because they don't even know that they're having these seizures. Their parents don't know they're having these seizures because they're unconscious during it, and all of a sudden they'll just stare off into space for about 30 seconds, and then they'll snap right back into it. So that's what an absence seizure is, and then knowing that spikes and waves are involved. Infantile spasms are also high yield. These are also generalized. So again, keyword for that, unconscious and bilateral. Know what this one looks like. So just know spikes and waves are a little bit more organized, absence, and then hypsarrhythmia, to me that sounds like a pretty crazy word, and so it's gonna look pretty crazy, right? So these are infantile spasms, and that's what that's gonna look like. Cool. I would say like the highest yield are knowing what those two look like. So then you have these secondary seizures, which are going to be partial or complex. I'm not really going to go into it because honestly those are pretty straightforward. Okay, I'm not talking about embryo. I put these here for you guys. I freaking hate embryo. You all know that. If I have to say know something, know these. Your Hox mutations, EMX, OTX. I did, for those of you who haven't like been on, I like, okay, so I like swear by the essential notes, but honestly those things were like even too dense for me to get through. They were like killing me. So someone made this awesome PowerPoint of all the embryo stuff you need to know. It's literally like every testable thing. And so look at that, it's on the Facebook page. That's all I'm gonna say about embryo, because that's all I know, honestly. I did it and I blacked out. Yeah. So hopefully that doesn't happen to you guys. You'll keep it in your long term for the step, because I need to relearn all that. Cool, so now we're going to talk about sensory. So I'm sorry for like the little mistakes I was making, so I want to say that, sorry. So sensory, let's talk about what's high yield for this. So yeah, it's pretty mean that they gave you like 2 really dense lectures right before your exam. What else is new? So let's talk about slow adapting versus fast adapting sensory receptors. This is really like important like for life, because we have these what they'll do is they'll give you like a scenario and then they can say like, was it slow adapting, fast adapting, and a bunch of other things. Well, you know, if the scenario is you're holding a baby, you want that to be very slow adapting receptors, because what it means is, like, how you feel the sensation. Are you going to consistently feel it, or does it go away and is perceived as normal immediately? So slow adapting does not perceive the stimulus as normal for a long time. That's why it's slow. So when I'm holding my phone, I'm still holding it because I'm perceiving this as abnormal. This is not a part of my skin. This is not a part of me. It's abnormal. This is slow adapting. Then fast adapting is going to be something like wearing clothes. And don't like think too much like abstractly of why does it be like this and that's like that? Like, are they different neurons? Yes, but use this as like a concept. So when I put on clothes, I kind of like forget I'm wearing them and almost like, okay, that's like a weird concept. So you don't like feel them like when they're on, right? You know what I'm saying? So that would be more of a fast adapting receptor. Yeah, that was weird. Okay, so this is how they can make it more of a testable concept as like an action potential. So your slow adapting receptor will have consistent action potentials, right? It's like constant stimulus, abnormal, 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 as opposed to rapidly adapting. It's like, yeah, that was there, now it's normal, so I'm not gonna really remember it anymore. Or remind you that it's there. Okay, this. Okay, convergence, divergence. Important when you get to I, which will be like on like Wednesday or something like that. But what I would like to do is give you like a concept for each of these briefly, because they gave us these illustrations and those weren't in your slides. So an example of convergence is basically, right, you have like a ton of neurons like going to one neuron and like all saying what's going on. So that's the stimulus. So an example of this would be the receptive field of a neuron, right? So we have like all of these first order neurons report to one second order neuron. So that's like as straightforward as I can make it. So you have a ton of first order reporting to the second order. So this is convergence. These are all leading to this guy. As opposed to divergence is this one guy is leading to multiple guys. You can tell I like simplicity. So this guy is my photoreceptor, and this is in the retina. So this is an example of where we could see divergence. So one stimulus going and telling a lot of different places what's happening. So that's really the most they could ask you on that, is just examples. Okay, lateral inhibition. They made it super complex for us. We had a ton of different slides on it, and you guys had like half of one. So I don't know if that means they don't want to test you anymore, which would be freaking awesome because it's really complicated and they made it nice and simple for you guys. So I left this in here if you wanted to see an example of what they gave us. All you need to know is that in this example of lateral inhibition, it just makes you more understand like where the stimulus is more precisely. So like let's just say there's like a +5 stimulus normally, and then there's like a +10 right here. Due to lateral inhibition, it will feel much stronger, like you'll be able to discriminate better. Actually, that's like the best way I can put it. Lateral inhibition allows discrimination. If you want to look at this math, feel free. Essentially, lateral inhibition allows me to know that this neuron right here was giving me the +20 output while everything was giving me 0 to 5 to -5. They took it out for a reason probably, but I just wanted to share all the resources I had with you guys. So lateral inhibition allows discrimination. Okay, receptors. Sadly, you guys do need to know this. I know that we did it like histoskin. So this is like the way that I remember it. So Merkels, because I always confuse Merkels and Meissners. So to me, Merkels sounds like nickels, and you know, like when you put your hands in your pockets and you feel coins in there, you're using fine touch, right? So Merkels, nickels, fine touch. And then you have Raffinis. I don't know how I wrote that. Like something's rough and you stretch it, so Raffinis is your stretch receptor. And then Pacinian, I always forget Meissners. So then you go to Pacinian, that's going to be your deep pressure, right? So now we're talking about vibration. So Pacinian's pressure, but intense pressure, right? It's going to be high frequency vibration. So 300 hertz. And then Meissner's is low frequency vibration. I always forget that one. So proprioception. All it is where something is in the air, but really brief terminology. You're gonna like learn this stuff really intensely. So just to be familiar with the words, like if they, honestly, I kind of brought a lot of these up so that you would know the wrong answers. So like they'll put things like Golgi tendon organ as an answer. You're probably, you like barely talked about that, so it's probably not a right answer, but I want you to know with confidence, that has to do with motor. That is definitely not a right answer. You know what I'm saying? So it's good to be familiar with those terms. So this is what they gave us for fiber classification. There's the rule of like 6, so we go from 0, 6, 12, and up. This was like in a different format in your slides. So I know this like looks really different. Again, all you're knowing is that 1 fibers are really fast and large, and 4 fibers are my unmyelinated, much slower. That's all you need to get conceptually from this. I just wanted to, I guess, prove that I wasn't lying. Yeah, so that's where that came from.
Why would we lie?
I don't know. So dermatomes, I'm not going to go into this, but they could help you with question stems. Okay. I'm going to pause the recording and restart it because it's going to stop at 2. You know what? Maybe I could do this in 15 minutes. Oh yeah, because this.
I believe in you.
Yeah, this stops in 2 hours, so I want to stop it. Okay, yeah, sorry. All right, moving on. So we have basically 2 sensory systems, right? We have touch vibration, proprioception, which is my DCML. And then I have pain and temperature, which is my ALS, also known as spinothalamic. Please remember that temperature is associated with pain. I don't know, that's like one of the ones that kind of gets thrown in the air. So we're going to talk about gracilis. Okay, so first we're going to talk about DCML. So totally forget about ALS. We'll do that in a few minutes. So DCML essentially is my somatosensory, right? Touch, vibration, proprioception. Now we need to know a little bit more specific. So before we learned that like all we needed to know was like the dorsal horns did sensory and like the ventral horns did motor. Not anymore. We got to know a lot more. So what I need to know is that my white matter in the middle is kind of split into 2. And let's see if I have a better image. I'm going to scroll down a little bit to just point it out a little bit better. Right, so here's my dorsal column, right in here. And I know that this is dorsal because they can flip this image on the exam because these wings touch the back. So this is my butterfly wings, right? And the ones that touch the back are dorsal. My ventral horns never touch anteriorly, right? So if they flip this upside down, you guys are still gonna know which side is dorsal because dorsal is the one that touches the outside. Does that make sense? So then right here I have my dorsal column. And it's split into 2. And we can't really see the actual split, but they'll make it nice and like demarcated on the exams. So this guy right here, nice and medial, is gonna be my gracilis, right? And gracilis is in charge of legs. How do I remember that? Gracilis is grass, right? And I walk on grass with my feet, which is my legs. Or the muscle, but Lord knows I don't remember that shit. So, oh my gosh, I was supposed to behave, I'm being recorded. Yeah, it's I'm bad. So gracilis was in the middle, and then we have cuneate, which is my arms. And so if I were to say, for example, at the T7 level, what does my cuneate look like? Well, it doesn't exist, and of course they wouldn't ask you a question like that, but just know that your cuneate kind of happens after you hit your brachial plexus, right? So we know that's like around the T1 and up area. So what I mean by that is from basically like T2 down, all that's in the middle is gracilis, because that's what's ascending upwards. And the arms haven't kind of jumped onto that yet. So they can make some interesting questions out of that. So this is out of the essential notes, not the essential notes, the neuroanatomy textbook. Okay, so this is going to be one of those things where like if you are like a neuro buff and you're like having a great time and you're like, give me some more stuff to learn. This is what I suggest. So you guys, like if that's anyone in here, I will slap you. So we know that like we have our gracilis medially, right? And then we have our cuneus laterally, which is gonna be our upper extremity. Pay attention of where it is in the medulla and the midbrain. So we know that like as it ascends, our sensory pathway, so it's gonna ascend, and then at the most inferior part of the medulla, it's gonna decussate, right? And like at the decussation of the medulla, it's gonna switch to the other side. So if I'm ascending up my right side, I'm gonna switch to the left at the most inferior part of the medulla. Can they make a super effed up question and say like, at the most inferior part of the medulla, where's the lesion? They're not gonna do that, so don't get like all worried. If they say medulla, it's already contralateral. They have never been that like mean. So in the medulla, just kind of notice that your lower extremity is more anterior and your upper extremity, it kind of does a little flip. I'm not going to talk about this too much if you want to, because if I talk about it, it'll get confusing. If you want to look at it and just know this image exists and just draw it out a few times. For you guys, you should be good enough knowing about gracilis versus cuneate in the dorsal column. Take a look at this image and just kind of, you do need to know where your medial lemniscus is in the cut of the medulla, the pons, and the midbrain, which I will go into. But upper versus lower extremity could help you out. It would be one of those like nice mean questions. So this is just ALS versus medial lemniscus tract. I'm not going to go into that. So I'm just describing the tracts very simply, and then I'll go into lesions, right? So we'll do like our syringomyelia versus Brown's core. So then ALS. So again, just kind of pay attention where arm versus leg is. This is going to be like one question that you would have to differentiate between the two, but it's kind of helpful. So something to note in our DCML. Our first synapse happens like really high up, right? Like at the medulla when we do that crossing, right? So we're gonna synapse either at our basically like gracilis nucleus or cuneate nucleus, depending on what we are, and then cross and then ascend to our thalamus and then synapse there, right? At our VPL, right? VPL. And then that's gonna go ahead and go because that's for our body, and you guys haven't done trigeminal yet, so we won't talk about that. Our ALS, though, synapses at the level of the spinal cord. So if it enters, and we'll talk about Lissars, don't you fret. So we come in through our dorsal horn, of course, and we synapse right there, and then we cross over and ascend. So we're not going to cross over again when we get to the medulla. So just kind of keep that in mind. So if you know what, we'll do that when we get there, we'll get there. So we cross at the level of the spinal cord. Keep that in mind. DCML, our first cross is in the medulla. So then we ascend, and it's called the anterolateral system for a reason because we ascend anterolaterally. This is important when we talk about Brown's core. So let's talk about Lissars tract. It's also called the dorsolateral fasciculus. Keep that in mind. They didn't use that word for us, but it can come up. So Lissars tract, so essentially, what's the point of Lissars tract? Well, we must know that if this exists, that pain is super important as a fundamental feature to keep us alive. Because if we did not have pain, we'd be doing stupid things all of the time. And even though we do have pain, we still do stupid things all of the time. So keep it in mind. This is the point. Because you want to be able to preserve this pain at many different levels. And that's why I drew this guy out earlier, which I freaking deleted at some point. Oh no, there it is. I was like, nice. Okay, so here's my general rule. We'll talk about syringomyelias first, and then we'll talk about Brown's core because that one's a little bit easier. Syringomyelia is a little bit easier. So syringomyelia is basically like a syrinx that goes like through the centralmost part of our spinal cord, right? And normally it's in our cervical spine, and I actually included a little picture. This is what they can make it look like on a CT or MRI. This is an MRI. So just keep that in mind. They could kind of show you that picture. And I think that knowing like what a syringomyelia is kind of allows me to demonstrate Lissars tract a little bit better. So the only time that you will affect pain with the syringomyelia is if you affect 5 spinal cord levels or more. If you affect 4, 3, 2, or 1, you will not have a problem. You will not lose any pain. I will demonstrate how that's possible. So let's just say we lose 5 of these. So I'm going to work from the top down to explain how, let's call this C1, C2, C3, C4, and C5. So you don't even have to tell me, I don't have to think twice, I know the only place I'm losing pain is bilateral C3. So, but I highly suggest drawing it out every time on the exam because it could get a little bit complicated. So basically C1 can come in on either side and it could ascend, right? Oh God, I probably shouldn't have used C1. So let's just say it's like C2 or something, right? And it would ascend to the next spinal level, cross over and go, right, due to Lissars tract. So that was really stupid. Also remember that my synapse is located where I'm crossing. So I would synapse here, go ahead and cross, right? I should have used C2, what an idiot. So then the opposite can happen on this side, right? So if I come in on my left side, I go up, I synapse at my imaginary spinal cord level, and I cross and I ascend, right? So for C2, I would go down and I would, I can't cross here, I can't go down, right? Because I can't cross at these two. But I could ascend, right? And I ascend here and I try to cross, oh, it doesn't work. But I could ascend to the next spinal cord level and go. So Lissard's track works 2 up and 2 down. So then I'm good to go there. Let's skip C3, so let's go to C4. So C4 can go, and you're like, oh, wait a second, can't go up because I wouldn't be able to cross at C3. I can't cross at C2, but I can go down, right? So I would go down to C5, can't cross, go down to C6, then I would synapse at C6 and be able to ascend in my ALS, right? Make sense? Yep, so then you ascend after you descend. So that's how that's able to work, like why it, does that make sense? Did they like not, they didn't talk about that? All right, cool, that's great. This is real life, it works like this. So then we can, because the only thing affected is the central area, right? So if I go down to C6, if I go down to C6 here, this is totally fine. I don't have my syringomyelia here, so I can across my ALS, and my track here works just fine. I could still ascend, no problem. Cool. So the only problem here is going to be C3. So remember my rule of 5, I can go 2 up, 2 down, and I don't have either option here, right? Because here I enter in, I go up, can't cross, go up, can't cross, can't do it. Go down, can't cross, go down, can't cross, can't do it. Boom, C3 is a bust. So if I have a syringomyelia from C1 through C5, the only thing I'm going to lose is bilateral pain at C3. And you could take what you want with that. So that's about it, I could say. Does that kind of illustrate Lissard's a little better, maybe? So maybe that was a little helpful. So they'll ask you it in the context of a syringomyelia, and of course in lesions. If anyone has any more trouble with that, I can review it again like afterwards, or like do some one-on-one or whatever you guys need. I just want to make sure I finish this because I don't want to keep you guys for too long. All right, so now this is for Brown-Séquard. Séquard, whatever. So Brown-Séquard is basically like a hemisection of your spinal cord. So situations where this will happen, neoplasms. I mean, honestly, this is like really big in prostate cancer. I don't know, pathology. So what's going to happen is, with syringomyelia, we said basically the only symptoms you're going to see are those like bilateral pain loss. But with Brown-Séquard, we see a ton of problems, right? So let's kind of just go through them step by step. So let's talk about at the level of the lesion. So at the level of the lesion, we're going to lose basically my dorsal horn and my ventral horn, which means at the level I have motor problems, which you're not going to go into too much because you'll do that with motor, but just know that there will be some sort of motor problem, of course. And my somatosensory, which is touch, vibration, proprioception, will not be able to enter, right? So at the level, I kind of have this little guy, but I'll go into that later. So at the level, we lose touch, vibration, proprioception from there down, ipsilaterally, right? Because I got rid of my dorsal column. So we know that sensory fibers ascend. So everywhere from there down, we have an issue with somatosensory. Same side, ipsilateral side. Cool, that's kind of like the more straightforward part. It gets a little bit weirder with pain. So with pain, we know that it still enters on the same side. So at this level, you are still going to lose pain at that level. So let's make it arbitrary. Let's just say this is T1. So at T1, I'm going to lose TVP, touch, vibration, proprioception, from T1 down on my left side, according to this example. And pain at T1, ipsilateral. That's all I could say about my ipsilateral side. But we know that I have my contralateral ALS on this side, and this is where things get a little weird, right? Because on my right side, I do that crossing for pain, right? I use my ALS tract to ascend, but I have my rule of 2, right? So this will affect contralateral pain 2 spinal levels inferiorly. Because the one like at this level, it could come across and ascend 1, right, and go across like just like how we demonstrated here. So let's draw a little, okay, so we have our spinal cord, right? Oh my God. This guy, let's just do 3. We'll say there's a hemisection here. I just want to be able to demonstrate the pain part and why it's 2 spinal levels down. So at the level, contralaterally, it can come in, ascend to the next one, cross there, right? Here, I can come, ascend here, ascend to the next one, and cross here. But then down here, so this is 2 down, so let's say T1, T2, T3. So I can come here, and regardless of if I cross here, I'm still gonna hit my roadblock here. If I cross originally, I'm gonna hit my roadblock here. And then if I ascend twice, I still can't cross, right? So this is why it's 2 below. So if I have to say, what does Brown-Séquard affect, like in words? Ipsilateral, TVP at the level and below. Pain at the level, ipsilaterally, just at the level. Like at this, you know what, let me use this a spinal cord for example. So let's just say this is at T1. So I would use ipsilateral TVP T1 down. I would use pain at ipsilateral T1 and then contralateral T3 down. I feel like if I explain this one more time, I'm going to make a mistake. So I'm going to kind of leave it there. Hopefully everyone kind of feels okay with that. So I tried to just like put this little guy here to just show how it's distributed. So this, I could say, just looking at this, if they were to just give me this image, I would say the spinal cord lesion is a hemisection, a left-sided Brown-Séquard at the level of, I'd say T5, right? We're just below the nipple line there. So T5 hemisection left side.
You have 30 seconds.
Cool. And that's, oh shit, 30 seconds. Okay, yeah, I put, I'm gonna stay for you guys. I just wanna like finish up with the people listening in here. So there's some images at the end, very high yield, take a look at them. Thanks for listening. Sorry for being crazy. Okay, thanks, bye.